Bismillahirrahmanirrahim. We discuss today cancer cervix. Cervical cancer is the third most common cancer in women worldwide. Cervical cancer is a disease that develops quite slowly and begins with cervical intraepithelial neoplasia. This cervical intraepithelial neoplasia is easily detected in routine pap smear, and so it is completely treatable and considered as a preventive method for cancer cervix. In this slide we show the cells of the cervix, normal cells, then starting to be abnormal cells till reaching the carcinoma in situ when the basement membrane is intact, then invasive cancer where the abnormal cell starting to invade the basement membrane. In the last diagram there is lymphatic vessels and blood vessels, and we must see that there is an area between the basement membrane and the lymphatic vessel and vascular vessels, and this is very important in staging of the cancer cervix. Incidence of the cancer cervix may reach up to 16,000 new cases in US will diagnosed every year, and about 5,000 women die from this disease every year. However, the incidence is decreasing due to screening programs occurring in US and many European countries, and in any country applying this screening program will show decreasing in the incidence of the cancer cervix. However, the incidence of the cervical intraepithelial neoplasia will increase due to increasing rate of discovery of this disease. What are the risk factors for the cancer cervix? The main risk factor of the cancer cervix is the sexual activity. This sexual activity, which must occur at a young age, as a young age of marriage, or a young age at the first coitus, less than the age of 18 to 20. Also, young age of the first pregnancy. One of the important characteristics of sexual activity which may lead to cancer cervix is the multiple sexual partners. Even if the female having one partner, but her partner having a multiple partner, this will increase the incidence of the cancer cervix. Also, certain male may have abnormal sperm with abnormal DNA fragment, may considered as high risk male. Second risk factor is the virus. The main virus is the human papilloma virus. Human papilloma virus was divided into three categories. Oncogenic human papilloma virus, which is 16, 18, 45 and 56, or non-oncogenic human papilloma virus, which is 6 and 11, and intermediate oncogenic human papilloma virus, which is 31 and 33. Also, this is the main virus related to the cancer cervix. Another risk factor is the high parity. High parity is one of the risk factor for cancer cervix. This may be explained by when the patient is highly parous. This means that the first coitus started at young age, and also there is more frequent coital relationship. The cancer cervix is very rare in virgin. Another risk factor is low socio-economic condition. Why low socio-economic condition considered as a risk factor for the cancer cervix? This because usually there is an abnormal sexual activity with at a very young age with multiple partners. The second factor is because the women in low socio-economic class not receiving a good health care and screening program. Another important risk factor is smoking. Smoking is related to cervical cancer, and the carcinogenic smoking product were detected in cervical mucus. Another important risk factor is the deficiency of the beta-carotene, vitamin C, and folic acid, and this is also present in the low socio-economic condition. Hormonal contraception is one of the risk factors for the cancer cervix, especially in the adenocarcinoma of the cancer cervix, because usually due to long-term use of the combined oral contraception, because estrogen component will produce a version of the endocervix and stimulate metaplasia, and so increase the expression of the viral protein. What are the clinical picture of the cancer cervix? When you take the disease, which is cervical intraepithelial neoplasia, which is an early or precancerous condition of the cancer cervix, one of the important feature of cervical intraepithelial neoplasia that it is asymptomatic and discovered by pap smear or colposcopy. But in cancer cervix, symptom starting with bleeding occurring between regular menstrual period or after sexual intercourse, or after douching or pelvic examination, which is the common early symptom. Also, the bleeding may be in the form of post-menopausal bleeding after coital relationship. Another symptom is unusual heavy discharge. This vaginal discharge may be foul-smelling, watery, thick, or even containing mucus. Late symptom due to spreading of the cancer may include flank pain or leg pain. On examination, cervical lesion may appear as exophytic, as in the right picture, or barrel-shaped, or in the form of ulceration, as in the left picture. The pathological forms of cancer cervix, mainly squamous cell carcinoma, which occur in 80 to 85%. Adenocarcinoma in 15 to 20%, or adenosquamous carcinoma, rare cases as glacis or stem or oat cell carcinoma, mesonephroma, tumors of mesenchymal tissue as carcinosarcoma, adenosarcoma, or other rare tumor as carcinoid or metastatic tumor. So the main pathological form is squamous cell carcinoma and adenocarcinoma. How cancer cervix spread? The main route for spread is direct spread, downward to the vagina, upward to the uterus, lateral to the parametrium and adjacent viscera, anteriorly and posteriorly to adjacent viscera, to urinary bladder or rectum. Second route is lymphatic spread through the lymph vessels. The primary lymph nodes are in the parametrium, paracervical, obturator, hypogastric, and sacral lymph node. Then will spread to the secondary group, which are common iliac, inguinal, para-aortic lymph node. Once invasion into the stroma of the cervix occur more than 3 mm, the tumor will access the lymphatic duct, and this is why in the figure when we see the invasion of the basement membrane and we show the lymphatic vessels and the blood vessel, once the invasion reaching more than 3 mm, the spread to the pelvic lymph node will occur up to 15% in stage 1, 13% in the stage 2, and patients with stage 3 are associated by about 60% of lymph node invasion. Bloodstream is rare and even in very advanced stage. Transcelomic implantation is very rare. This transcelomic implantation will be seen in the ovarian tumor more than cancer cervix. In cancer cervix, it is very rare. This is a diagram of the lymphatic spread, paracervical, then to obturator, and common iliac, and then aortic lymph node, primary and secondary lymphatic spread. How we diagnose the cancer cervix? In a very early stage, before appearing any manifestation or signs, can be diagnosed by pap smear and colposcopic examination after applying 3 to 6% of the acetic acid to the cervix. Later on, when there is visible lesion in the cervix, we can diagnose by history and complete physical examination, including vaginal and rectal examination, and usually also we need examination under anesthesia to see if there is space between the extension in the parametrium and the lateral pelvic wall. Ultrasonography, especially transvaginal ultrasonography, may help to assess the extent of the pelvic spread in the of the disease. Also, diagnosis of the cancer cervix must be confirmed by biopsy. Never diagnose cancer cervix without biopsy. Biopsy can be taken if there is a lesion, apparent lesion, by bunch biopsy or excision biopsy in the of the lesion. Sometimes we need comb biopsy if there is no visible invasive cancer, or we consider the adenocarcinoma. Endocervical curettage may show the adenocarcinoma in the cervical canal. Also, cystoscopy and proctoscopy are essential to assess bladder or rectal involvement. Routine blood and urine examination, radiological investigation including intravenous pyelography, CT, PET CT, also X-ray chest, skeleton X-ray, barium enema, MRI, all to diagnose the degree of the spread of the disease. How to prevent cancer cervix? Prevention of the cancer cervix depends mainly on the screening, which regular pap smear screening will reduce the chance of the female to die from cervical cancer by about 90%. Also, vaccination is one of the prevention. Vaccination to young girl at the age of 9 years. There are two types of the vaccine containing against two virus, 16 and 18, and a vaccine containing against 4 virus, 16 and 18, which is the most common human papilloma virus causing cancer cervix, in addition to 2 non-oncogenic, 6 and 11. How to stage cancer cervix? Cancer cervix is a clinical staging. That means we must do every investigation before any operation to stage cancer cervix. Cancer stage 0, FIGO staging. Cancer stage 0 is carcinoma in situ. Stage 1, the tumor is confined to the uterus, to the cervix, and if it is extended to the uterus, it is not affecting the stage. It is divided into stage A and B. Stage A is microinvasion. The microinvasion is less than 5 mm and there is no gross lesion. Stage 1B, more than 5 mm invasion, or there is clinical lesion. Stage 1A is also again divided into stage 1A1, which is the invasion less than 3 mm breadth, deep, and less than 7 mm breadth. And stage 1A2, between 3 to 5 mm invasion. In the second stage, stage 2, divided into either stage 2A or stage 2B. Stage A, there is no parametrial invasion, but the invasion passing to the vagina, but sparing the lower third of the vagina. In stage B, there is invasion of the parametrium, but sparing the pelvic wall. Stage 3, there is invasion either A or B, either invasion to the lower third of the vagina, B, there is invasion parametrium reaching the pelvic wall. Stage 4, either spread to the adjacent organs, anterior urinary bladder or posterior rectum, or B, spreading to distant organs, to the liver, to the lung, or any other distant organ. How we treat invasive carcinoma? Treatment of stage 1A is 1A1, either cone biopsy or simple hysterectomy. What is stage 1A1? Is the invasion less than millimeter deep and less than 7 millimeter width. So this can be treated by cone biopsy or simple hysterectomy. If the stage is stage 1A2 or stage 1B or stage 2A, the treatment either radical hysterectomy or radiotherapy, except in some selected cases of stage 1A2 which need fertility, so can be treated by what is known as radical tracheolectomy with pelvic lymph adenectomy. Treatment of the stage 1B2 to stage 3, stage 4A. Treatment is by combination of radiotherapy with chemotherapy is the standard of care. Surgery can be considered as adjuvant therapy in residual tumor or after definitive chemotherapy radiation. Stage 4B, chemotherapy should be used for disseminated disease, and radiotherapy can be considered for pelvic tumor control or for palliation of symptoms including bleeding. Inoperable treatment or operable tumor, we have the choice for surgery, which is radical hysterectomy with pelvic lymphadenectomy, or radiation. So what is the advantage of surgery on radiotherapy? Firstly, ovarian preservation. Secondly, better sexual function. Thirdly, decreased incidence of cystitis and enteritis, and also can be used for recurrent, centrally recurrent disease. But the disadvantage or complication of surgery is the transient bladder dysfunction, formation of the lymphocyst, infection after operation, pulmonary embolism because this is a major operation, hemorrhage during operation, and formation of the urethral fistula. However, the advantage of radiotherapy that the radiation is very viable for treatment for people with locally advanced disease, can be used as symptomatic or palliative management. Also can be used when the disease is confined to the pelvis in early stage in patient with unfit for surgery or very old patient not needing ovarian preservation or sexual function. Also radiation is an symptomatic control for metastatic or bleeding from central tumor. The prognosis for cancer cervix, which is the 5-year survival rate in patients with cancer cervix according to the staging. In stage 1, radiotherapy is 90% and surgery 86%. Stage 2A, 85%, 75%. Stage 2B, 66 to 58%. Stage 3A, 45 to 45. Stage 3B, 36, 30. 4, 20 to 15. So the treatment or the 5-year survival rate are very comparable.